Well, again, my name is Virginia Matfeld, and I'm a dental hygienist. I'm also what some of you may have heard who have friends that are dental hygienists, an expanded practice dental hygienist. And what that means is that I have the opportunity to work unsupervised out in the community, and I also have my own practice in a wellness center to provide care for low-income, uninsured, and members that are on the OHP plan. So today, I'm really passionate about interprofessional collaboration. It's been in existence, it's been talked about since 1965, but as anything else in technology, it takes forever to start implementing. So it is something I'm very passionate about bridging the gap to oral health. You guys are at the forefront line when you see the patients come into your office. So I thought this was a really great topic to start going out in the community to nursing students and just putting that seed out there to start thinking about when you're talking to your patients about asking oral health questions and quick assessments. Our objective will be basically let's see, what are we going to talk about? Well, I have 3 objectives that hopefully that we can incorporate once you get out into the community working as nurses, and that will be that you'll be able to identify the benefits of nurses and dental hygienists collaborating. Also, I apologize, being able to explain oral and systemic health, as well as being able to display respect out in the community with other health providers to break down these barriers and start collaborating with other professional providers out there. So basically what we're going to talk about is increasing your knowledge about what a dental hygienist does. There's a lot of misunderstanding that we just clean teeth, but there's a lot more to it. We'll go over about increasing oral health systemic awareness, how we can integrate preventative interventions, as well as integrating dental hygienists as part of the healthcare team, and also integrating them into a clinic as well. So the World Health Organization identifies interprofessional collaboration is when you work with multiple healthcare providers from different professions, and you come together as a team to provide the ultimate care for your patients. So collaboration is when nurses, well for me, for my presentation today, is how we can work together as nurses and dental hygienists out in the community. And integration is how we work in the healthcare setting, hospitals, clinics, private practices, nonprofit practices. And so it's starting to happen. It's very slow, but there are some dental hygienists that are currently working in some healthcare facilities, as well as nursing homes. So right now, why interprofessional collaboration? It's because where healthcare is heading to right now. And like I said, I'm very passionate about it. It's when we want, once you see your patients in a clinic setting, it's a way of handing them off so we get that information transferred over. So it's a continuity of care. We promote coordination of care across the continuum of health in all healthcare settings. Also, nurses and dental hygienists are part of the healthcare team. We promote sharing of knowledge and working towards the common goal, which is the patient's ultimate health. Nurses and dental hygienists, we are all invested in our collaboration as partners. We all have a key role as professional healthcare workers. And some of you may have, in some of your classes, I'm not really sure where you're at in your learning. I know you're dealing with geriatrics, which I also do mobile for seniors in assisted living and memory care, which is something I'm also very passionate about, and I have a couple case studies that I'll go over with you. And the triple aim is basically to improve the health outcome, to improve the quality, as well as at a low cost. So what are the benefits of interprofessional collaboration? One is we want to improve safety. We want, as far as delivering healthcare, we want to reduce the cost of healthcare. Healthcare professionals and patients, or excuse me, the healthcare professionals and patients also have to work together in a patient-centered care. That means that the patient also has to be involved in their care as well. And with better coordination, and there's better treatment plans for the patients as well, we're able to make informed decisions for the benefit of our patients. And why, when you stand up here, yeah. Okay, grab it. So, also, additional benefits for interprofessional collaborations is we want to enhance communications among different disciplinaries. We want to minimize duplications or efforts and increase each other. So what we want to do is we want to understand each professional's scope of practice. So then we know how to collaborate with, for example, if I have a patient that had knee surgery, the protocol is they need to have antibiotics pre-med before they have treatment. Well, we're finding that the patients don't recognize that, and so it's an education at the clinic with their providers to let them know that this is why you have to have it so we can do our job. Interesting story, my daughter in 2nd grade, while I was going through dental hygiene school, her teacher was telling me she knew I was going to be a hygienist, and she was telling me about her dental visit. And within a few hours, she was in the emergency surgery for endocarditis. She didn't realize that the bacteria from the plaque gets into your bloodstream, and within hours, she had to have open heart surgery. So it really is key that we start educating our patients about medical and dental coming together. But it also builds relationships with our professionals, as well as learning, like I said, it leads to better understanding what each of our disciplinary providers out there do. Mutual understanding and support, like for example, clinicians, therapists, and specialists, like I was saying earlier. And so there's 4 core components or competencies as for interprofessional collaboration. And that is we want to value ethics and professional practice. We also want to make sure that we are cognizant of roles and responsibility as collaborative practice, as well as interprofessional communication. We want to make sure that we have that communication because I have seen that time and time again where I will call a doctor's office and we want to know what medication they're on and we don't get called back. And then the patient gets upset at us because we won't do the treatment because we didn't get this from the healthcare provider. So I think as we start doing more and more collaboration, we'll start having a better communication between different disciplinaries. And of course, it's all teamwork. This is really, I found a photo which I was really excited about that there's a college. They are actually doing it was in December, it was a story that was written up about a university that's doing a collaboration. So they're working with nurses and dental hygienists together to provide care for their patients in that clinical setting. And that was a hard photo to find. The role of a dental hygienist. We are not prophy busters. We do not just clean your teeth. And sometimes you'll hear that, are you gonna poke me with that little pokey thing? It's like, so, yeah, I'm gonna prepare your chart. But what we are is we are licensed dental hygienists. We go to, I probably went to school with many nurses when they were doing all their prerequisites. And then when it came to deciding what path, some went to nursing, some went to hygiene. So, but we are licensed professional. And then as I said, I'm an extended practice dental hygienist at Oregon. We're very progressive in the oral health, that they have recognized that hygienists are qualified to work independently. So I have additional credentialing to allow me to go out into the community without being supervised by a dentist. And so, like I said, I have my own practice in a wellness center, which is, it's nice because when I get calls, the first thing they ask, are you taking new patients? And they're having problems finding a provider that is taking new patients that are on the Oregon Health Plan. We are, like I said, we provide care in various settings, and we also, what we do is we provide preventative, educational, and therapeutic dental services. And also, like for myself, I decided to go back to school to get my bachelor's. And you can actually go into research, be clinical, educator. There's a lot of professional roles that dental hygienists can progress, advance their career in. So as far as our professional roles, like I said, I'm the hygienist. My passion is public health. And someday I like to be an educator, but I also like to do clinicals. I think for me, they tie together. You can be an advocate, and I guess I realize that I am an advocate for the people who are underserved to make sure they have access to oral health. And again, like I said, these are some of the settings that hygienists are allowed with their expanded practice to hospital settings, federally qualified health clinics, private nonprofit medical centers, as well as a nonprofit, and then being independent. Our role as a clinician, we have an organization which, like nursing, will have their nursing association, I believe it is here in Oregon, where we have 6 components. We collect the data, which is we assess. There's a lot of steps that are involved in assessments. When the patient comes in, we have to review their health history. We also have to take their vitals, blood pressure. Once we've collected data, also perio charting, that's all in there. We do a head and neck assessment for oral cancer screening. Many times hygienists have found we can't diagnose, but we can identify abnormalities. So when I see something as I'm in there working, when the dentist comes in to do the exam, I will point out something that is concerning to me, and then he will look at it. If it's concerning to him, he will have the patients go and have a biopsy. There's been many stories where hygienists have brought that to their attention. They had biopsy done, they had oral cancer. Some of them, when they realized they had it, they didn't go right away. Then it was too late. They were in stage 3, stage 4. And dental hygienists can diagnose periodontal disease, especially me out in the practice. We cannot diagnose cavities, which we are highly experienced and qualified, but we can't do that yet. We plan their treatment. For example, if a patient has 5 or above millimeter pockets, that's an inflammation. They've got an infection of the gums, and so we start a treatment, which many of you probably have heard. People call it deep planing, but it's really scaling and root planing. We're getting down into those deep pockets to remove the bacteria that sits in the plaque. And then what the bacteria does is it keeps destroying the ligaments in the tooth area. And so we have to clean it out and then keep them on a regular 3 to 6, usually 3 to 4 month treatment plan. And then once we've done the plan, we implement it, which is SRPs. Then we have the patient come back about 4 to 6 weeks to reevaluate. So what we do is we make sure that we do a perio chart, that the perio charting, the numbers have gone down, and if they don't, we do another round of scaling to make sure we've removed all of the bacteria out of the pockets. And so there's my little pokey thing that all the patients come in and say, are you going to poke me again with that thing? It's like my perio instrument. So what we're looking for is healthy gums are 1 through 3 millimeters. 4, I don't worry about it, and so I usually ask my patients, and I don't go to the flossing and brushing. I try to tell other hygienists, you need to think outside the box. You need to look at their health, something that's going on systemically. I had a lady that I looked at her history. She had normal perio charting numbers, 1 through 3. Nothing concerning. I noticed that along the margin of her gums, there was some inflammation going on there. So the first thing I asked her, I said, is there anything going on, like, stressors in your life, new medications? And she goes, no, not really. I go, okay. So I went back to cleaning. And then she raised her hand and I withdrew. And she says, I'm going through menopause. I said, there you go. I just read an article, evidence-based systemic review on women with going through menopause and the oral health effects, which there's a lot of effects that will happen because they get dry mouth, they can get cavities, they get periodontal disease. So there's a lot of oral issues that do take place through hormones. Well, when you're pregnant, women who are pregnant, their gums bleed. So again, it's hormonal. We also assess the hard and soft palate, the throat, the tongue, the gums. I tell my patients, it's like when you do, when women, we always tell them to do breast exams for breast cancers. I tell my patients to do once a month, just retract your cheeks, kind of look at your tongue, wiggle around, look at the borders, kind of lift your lips. Because if you notice something that's abnormal there, go in and have it looked. You don't know what that is if you've never seen it before. So I try to get my patients to actually look at their own oral tissues. And then, like I said, we do the head and the neck and the soft tissues of the mouth. So then we identify the needs to also then we start the intervention for our patients. So then once we've done that, sometimes if a patient has pockets that are, usually I can do 7 to 8 millimeters because I have specific instruments specifically for that, but not a lot of offices do. So a lot of times they'll refer them to a periodontist where, and I'll be honest, I'm actually, even though it's under control, I am a perio patient. Once you have perio, you'll always be a perio patient because you're susceptible to it. And I have had the flap where they had to open it up surgically and get down there and clean it out in order for me to go revert back to healthy tissues. So we usually send them out when they have about 7 and above millimeter pockets to see a periodontist for treatment. Let's see. We also counsel the patients on tobacco cessation, nutrition, anything that relates to their oral health, medication. So there's a lot more that we do clinically. We review and confirm their hygiene care each time they come in. Sometimes they'll say, yeah, I'm flossing really well. And I'll ask them to show me. And again, like I said, I don't floss shame. I think going to flossing and brushing first thing is wrong. We need to look at what else is happening in their mouth. And sometimes I'll say, oh, well, maybe let's try this technique or let's try something else, and then I find that patients are much more compliant once I've done that. And then, I'll implement the treatment, I'll monitor the patient, and I also, when I monitor the patient, if I'm doing SRPs, I'm also licensed to do anesthetic, but being an independent practice hygienist, I can't do nitrous. Although I am licensed for it, I can't do it in my own office. I have to have a dentist present for that. And then, like I said, we educate we educate our patients for appropriate health self-care when they're at home. We also, like I said, everything that we do is measurable assessments, so we can evaluate the outcome. We determine the needs for additional diagnostic. We also refer. We continue care based on the treatment outcomes, and we want to make sure that our patients understand and they take responsibility for their own health care. Flossing once a month doesn't cut it. And it's funny because people will say, I floss every day. Yeah, you do. Maybe once, but you can tell because it does, the tissues respond to not flossing properly. It really does. We also record all of our information. Everything is a legal document, anything that we talk to our patients. So it really makes a difference. So then that way when you come to me as we're collaborating, then that way I have, yeah, John said this and this and this or whatnot, then that way we have that continuity of care. Or if I need to call you and find out, you know, he was saying he's taking pre-meds, but he didn't have them with us, so we kind of coordinate that as well too. And then of course HEPA. That is a huge. I also work on a lot of community services with ODS, and I think I've taken 2 HEPA courses and fraud, waste, and abuse courses, and it's amazing how many people, you know, abuse the system. And so when I do my documents, I mean, they're thorough, because I don't want to ever get caught up in the news doing some Medicaid fraud. Again, like I said, I administer local anesthesia, nitrous, I prescribe fluoride, and then also antimicrobial. I also place temporary fillings. It's not really, it's actually a temporary material. And we also place the permanent, which is actually sealants. Now in Oregon, they're really big now. They passed a legislation law that all children must have sealants. And so when if any of you are working in pediatrics, that's a good time when you start incorporating these oral health questions. You can look to see if they have sealants. It's really easy. And I think that's something too that needs to be, is having continuing education, so then that way they put a oral health component together so you know what you're looking for. It makes a big difference. And if they don't have sealants, then it's always a reminder to the parents, you know, we need to refer you to your dentist, if you have a dentist, to get those sealants, because that will prevent cavities. So here's my healthy, and of course they have a little slides that I found, and I remember that in anatomy and physiology. Gingivitis, you can see we're starting to get a little puffy and red there. And then here we have periodontitis. You can also see where the gum has receded quite a bit, because right in here is the root surface. And that's also susceptible to cavities, a lot of root surface cavities. And I have some pictures that I'll show you of some of my seniors that it's heart-wrenching with that. So what is periodontitis? Well, it's a form of advanced gum disease. It's caused by bacteria that's in the plaque. It develops, usually it's mild, gingivitis, and then if it's not, the patient doesn't change their home care, then what happens, it progresses to mild to advanced periodontitis. They'll notice it by swelling of the gums, bleeding, discolored and receding gums. But then let me put a little thing to that. If, for example, if a woman is pregnant and she has bleeding gums, that doesn't mean she has periodontal disease, because that's a hormonal. So that's where all this, you have to do the assessment. We know she's pregnant, her hormones, her tissues are going to bleed. And of course, periodontitis is preventable by regular good technique of brushing and flossing. I like this one because it actually really addresses a lot. It says, what happens in your mouth doesn't stay in your mouth, and that's very true. 80% of Americans have gum disease, and cavities are caused by the bacteria in the plaque. What happens is, sometimes if you went out partying on the weekend and your teeth feel like they got little furry slippers on, you know, you kind of scrape it, that's plaque. That's reality. And so if you, I don't know if you guys do microscope in labs? No?
Prereqs. Yeah.
Oh, is that prereqs? Okay. Well, in hygiene school, we did. We had to, it's a great educator for us as hygienists. We had to actually do slides, and we showed the patients really what was in there. And they actually see, and so it's an educational tool for them. But it is really important to know what's in there. So oral bacteria, they're being found in the brain tissue, the heart vessels, joints, and many other parts. Gum disease also increases the head and neck cancer, which is heart-wrenching. I had a nurse, actually it was my first interprofessional collaboration, which I was really excited about. She was referred to me, my office is over by Portland Adventist, and she's an oncology health navigator. So she helps patients navigate the system to get care. So she had a gentleman who was on Medicare, but he didn't have dental, which is Medicaid. So she was trying to reach out to the community to provide free dental care and have him, he had to be signed off for oral surgery for oral cancer. Well, nobody would do it. And then I get the call. Well, my nature, I could not let somebody who needed a life-threatening surgery for, an $80 dental cleaning. I go out to dinner twice a week and that's $80 right there. That was nothing. So I told her I would do it. His tissues, by the time they were done, because when he has to go through head and neck radiation and chemo, it really affects the oral tissue. He ended up losing his teeth. So now I'm helping her try to find resources for dentures, because now we have another issue going on. He's not getting nutrition because he can't eat, because he has no teeth and he has no dentures, and he can't get dentures. So this is where the interprofessional collaboration would benefit, because then we can help somebody like this to get dentures so he can eat. So, it worries me, because now with his nutrition is being affected, there's going to be other systemic issues going on. They've also found in pancreatic cancer and kidneys, and that one was a new one to me as I was doing my research. The big one now is diabetes. Insurance are now covering an additional cleaning for patients who have out of control diabetes, because it's an inflammation. So same thing with women who are pregnant. Insurance are now paying for it, because insurance are starting to recognize the oral systemic association. So now they're starting to pay, and they're actually having diagnosis codes that cross over. And of course, diabetics have had a few that their gums bleed just profusely. You would think they were a patient that was on Coumadin or something. I was a medical assistant, so I took a lot of INRs. And one time I had a lady that I did, and I forgot to put a Band-Aid on. She goes, "Oh, I don't want a Band-Aid," and she comes back in like all over. She should have took the Band-Aid. But anyway, so gum disease caused tooth loss. There's also recently, and I was going to look for the research, recently just came out in the news about the bacteria in plaque is associated with Alzheimer's disease. And I'll have to look that up, but I wanted to get that and I just didn't have enough time. So that was quite interesting. Because like I said, I see a lot of patients in dementia with Alzheimer's. It's also linked to blood vessels, heart attacks, and strokes. This is my gentleman. I loved him dearly. His daughter seeked me out. I visited him, and for me at the time, I was new to Alzheimer's patients, so I wished I had taken courses like in nursing, the cross interprofessional collaboration or education. So I was just learning about Alzheimer's. He seemed normal to me. He would have his little cart and start strolling around there, and he'd say, "Virginia, do you think I belong in here?" Because some of the patients there, it's heart-wrenching that they're just sitting in a chair. There's nothing there, and it's really hard. So I go, "Well, no, John, you're doing pretty good, But I didn't know what to say, because I didn't know what was going on, and I was still new at dealing with patients with Alzheimer's. He died about a year later. I guess he had fallen, and so then that declined his health, which was really heartbreaking. But he was sweet. He was edentulous for 15 years. He only wore his uppers, and then his lowers were missing. And then he was on his second pair. So he was on his second pair, and then missing his lowers. Anybody could have picked him up. He was diagnosed in 2012 with Alzheimer's. He had a stroke in 2008, and then was diagnosed also with hypertension. These are the things that we look at when patients come into our office. Hypertension, stroke, anything like that, because it does affect their oral health. I did his vitals. They weren't too bad. But this was his denture. He said he was brushing his teeth daily. And I can't not tell him, "John, you're not brushing," because it's just hard. I don't want him to feel bad, I did try to talk to the caregivers to maybe help a little bit when he's not, but that's his upper dentures. And like I said, he cleans them nightly. And then when I did an oral assessment, when I retract his cheek, When I elevated his cheek, I found a lesion up there, and it is a stomatitis on the upper jaw, which is the oral lymphocytis. And what it is, it's an ulcer. But they can hurt because if it's on one here, they can be throughout the mouth, and then they're not able to eat, and then you're talking about nutritional effects from that. So now we'll get into caries, because you will see a lot of children. If you're working in pediatrics, you'll see children, and this is how we can collaborate with, doing a few extra things in the clinic for children. So we know that sugar plus our little bacteria, they make an acid, and that acid attacks the teeth, which of course cavities. And when I teach children, I always tell them, because I have a book that I tell them is Super Bug Doug, and he's peeing on the tooth. He goes, "Oh, what's he doing?" I go, "Well, what do you think?" "Oh, he's peeing." Well, there you go. And so it sticks in their mind to make sure that they brush and floss. But this little guy here, when you start, if you just have them lift their lips, and you see this little yellow, the enamel's breaking down, that's the start of decay. That's even before I went black, gray to black. And these are the kinds of things that you can actually spot in the clinic, even if they're not going into. And this is how you navigate them to see go to their dental home. Here's one of my other gentlemen that was in a care facility. He's, missing a lot of teeth. He's not brushing. You can see here plaque, got infection going on there. Same thing here with that. And what happens is they try to brush, but they're not able to, and then the caregivers, they're overworked, that when they give them their bath, they're not brushing their teeth. So that's another thing that many of the hygienists who are expanding practice that are going out into the community to educate the nursing staff at these facilities. So we can at least make it healthier for them, because it will affect other systemic. I found this, and I was going to print it out, but what I can do, I like to find, when I get resources, I have a file that I save, and it's like all my research, so everything is broken out to like anything that's oral health or heart. So I create files for research that I found, and I save it, because sometimes I will go back and refer it. And this was a really great an oral health risk assessment that can easily be done in the office. And this was for pediatrics. And I like it because it wasn't a lot of just checking the box. Again, here's some adults where you have the enamel, that's root surface, and that's where a lot of decay will happen. And these are patients that are in care facilities. So it's really heart-wrenching. And so we're trying to educate. There's a lot of care facilities, but we want to educate how important it is to get their oral health under condition so they don't have this. The new miracle drug, and I don't know if any of you have heard of it, it's called silverdimine. Now I know in Oregon we have the fluoride, we have two sides of fluoride. I don't go on the platform, I know what I believe, if everybody believes, but silverdimine is a product that was, I guess it's been around, but they know that they're using it for children and seniors in assisted living where the families can't get them in to see a provider. And what it does is it's an application, and it stops the decay and it stops the pain. So for children, they don't have to go in and have trauma on having the cavities taken care of. It's a great thing. The only problem is it makes the tooth black. That's why we don't put it on permanent teeth. People who have nice teeth, they have a cavity. No, we're only doing it for.
My daughter had that done. She had her last molar. It developed. It didn't fill in completely. It had like a hole in it, and so we didn't want it to get a cavity. So they went ahead and filled it with the silver.
Yep.
And it's not black for her. It's just
but
gray color, but they sealed it.
Yeah. Oh, see, that's perfect. And that's the other treatment that they're doing. Is they're placing the silverdimine, and then they're placing the restorative over the top of it while they get it. Let me tell you, I do screenings for preschool children and Head Start, low income, and I'm telling you, I am seeing a lot of stainless steel fillings, a lot of decay. I've had one little girl that's come in screened twice, and we classified her as a 2 because when I see a lot of bombed out decay, I asked her and I said, "Sweetie, when you eat or drink anything, does any of your teeth hurt?" And she'll, I go, can you point to them which one that hurts you? And she'll do that, and so again, the second round, and nothing was done. So, in my opinion, if I go back to screen the next time, I'm a mandate reporter, I will report it for child abuse. You know, so as a mandate reporter, it's important because I feel that I have to be an advocate for the children if I see something like that. But yeah, these are my patients in care facilities. And then, of course, this is a great photo, just showing you like different little decays that's just kind of forming just little pits and things. But those are, like I said, those are quick and easy things that you can see in the office. It looks like this one is black here, like they placed the silver diamond there and right in that area. And it does take a couple applications. And like you said,